So I think we'll get started soon. Just for everyone on the line, I'm pleased to introduce Parvin Mousavi, who is speaking to us from Queen's University. She's a professor of computer science, ECE, and pathology and molecular medicine, a very long title. And she's also a member of the Royal Society of Canada, which she represented at the summit of the G7 Academy of Sciences. Her research interests are in ML applied to oncology, computer-assisted interventions, and neurology. She leads the medical informatics lab at Queen's University, and we're glad to welcome her on the Vector Zoom. I wish that we could welcome you in person. But one of the good things about, I guess, quarantine is that we can have some more conversations with people across Canada, not just the UT and Ryerson folks. So do you prefer, so if people have questions, should they interrupt you or wait till the very end? What's your preference?
Do you think we can use the chat?
Sure.
Is it possible if they post on chat, and if I can manage myself and look at the chat from the time to time, I'll try and incorporate answers within. And then if I can't multitask very well, then I'll wait until.
Okay, wonderful. Yeah, we'll try the chat first. And I'll just mute myself, and I'll let you take it away.
Thank you. Thank you very much for the opportunity to speak to the Vector community and for hosting me, and hopefully there'll be opportunities to do this in person later on. So I know you expect to see a slide here. It's not a mistake. Before I start on computer-aided interventions, I wanted to take a few minutes to recognize the times that we are going through and the events of the past few weeks. And the call for us to learn, listen, and essentially strive for justice and equity and doing better, not just as individuals, but as scientists. Two aspects of our job, in my opinion, make us obliged to do this. One is that we are privileged to be publicly funded, and it is very important to consider how we are using this public support and giving back to the public to making our society a better place. But through our research as well, especially where my research sits in the intersection of health and machine learning, thinking about how the methodology and solutions and technologies that are developed are taking into account all the questions and challenges our society is facing for everyone, not just for a small number of patients or an elite group or small centers across the globe. The societies of the Academy of Science, societies of G7 has been thinking about this in their past letter. So 2019, AI and Society was one of the letters that they released. And the very first point there, you don't need to read the slide, but is careful stewardship is necessary so that the AI benefits are shared across society. So three things for us to think were highlighted: who benefits, and the bias in technology and data that we use and develop, and finally transparency of it and how is it going to impact and what policies it's going to impact. In Canadian perspective as well, Canadian Chamber of Commerce also has done 3 very nice studies 2 years ago and released documents. One of the documents was on AI and inclusion, and it incorporated long interviews with a large number of people from both public policy and the companies. And what they came up with is that although at the time we were the 3rd largest concentration of AI experts in the world, only 4% of Canadians were confident in explaining AI, and only 8% of the companies were willing to put in efforts towards addressing what I just mentioned, which is 20 to 40% fewer than the global average. So there's a lot of room for us to do as Canadians and researchers a lot better. So let me move on now to to my scientific talk and acknowledge all the students, investigators, collaborators, patients, clinicians, nurses, current and past, who have contributed to all the work that I'm presenting, the slides that I'm presenting and using, and I present this on their behalf. Computer-aided interventions refer to a collection of data that is collected through biosensors, multitude of biosensors, along with computational methods to come up with essentially help and assistance in decision-making in the clinic and augmenting such decision-making. They have become a cornerstone of modern medicine, and it is believed that their impact on medicine will be very similar to how computer assistance impacted automation. Despite sometimes the overhype of AI discoveries and how they might apply in medicine, on the ground, the trend has been positively impacting health. This shows the growth of AI and deep learning and investments in that area over the years. If you look at the graph, at the top graph, you'll see the trend going tremendously high around 2015 and 16 in red, and the trend of investments from companies continues. This is from 2018 in the bottom graph to quarter 3 of 2019. Along with this, data has also become, we are able to not only collect data, but also analyze data. So if you compare data of the past ORs with very few points to what is currently possible and not so distant future, not only do we have devices, technologies, data, but also the interconnection between all of this information, and taking the information back to the clinician or interventionalist and learning from it in real time is crucial. So in science and in CHI, similarly, we have moved from hypothesis-driven science towards data-driven science. And the question has been on the mind of many, and I think we are getting better at answering this question, is whether this is a demise of medicine and whether this is MD versus machine, even though there have been multiple busts, and one of them being the Anderson-Watson project that went bust, or is it really that we are augmenting medicine? The now previous head of the American Radiological Society put this in really nice terms in one of our recent conferences, Mackay, where in her words, and I cite her here, I quote some of her findings here, that clinicians that embrace technology, and particular machine learning and AI, are more likely to be replaced than those who don't. And she calls upon us to think about history and learn from what has been around. So computer-aided diagnosis has in fact been part of radiology in particular, and breast cancer detection for decades. It's nothing, the concept is not new for them. But what happened with the previous solutions is that they failed miserably. And the reason for that, in their opinion, is that the clinicians didn't care or demand better. So a few points that she puts forth, and I want to emphasize those in the projects I present today, are to essentially have to start with the clinician in the loop and the clinical question driving the solutions, to think about the technology or methodology that we are developing and how it affects productivity and decision-making. And then finally, to think about how you're going to deploy the methodology and to ensure that it is integrated within the workflow of decision-making in the clinic. So instead of MD versus machine, we are essentially doing an augmentation. And it's really not AI in artificial intelligence, but augmented intelligence that we are thinking about. In reality, the uptake of, however, a lot of the developments in clinic with systems that are making impacts have been slow. So in my talk, I want to emphasize within 3 examples, why is it that this uptake is slow? What are the challenges and what are the considerations that should be taken into account? 2 important things, and these are intuitive and you can almost see them or think about them without having been told, is that medical data is noisy and imperfect. So in the top row, especially the top left, I have a picture of a modern OR. So there are a lot of devices in addition to what is usually in an intervention theater, that you see machines, imaging machines, you see cameras that are mounted on the ceiling that the patient or the tools can be tracked. So there's a lot of information. However, depending on the center, the operator, the disease, the phenotype of the disease, and the patient, all of the information that is gathered is very variable, both the quality as well as the variation between centers. If you look at the cartoons in the bottom row there, you see a cart-based ultrasound machine that is high quality, low noise versus a handheld device point of care. Again, data quality is not only dependent on the technology, but whether or not it's a novice or experienced person taking the images, and hence the clinical interpretation and decision-making are very different. The second challenge is the noisy labels. Disease are heterogeneous. The same disease in different people has different signatures, so it's quite heterogeneous. Not only that, but the labeling, the gold standard labeling of disease, which is often through pathology, itself is heterogeneous. And that is not just because of the disease and the phenotype representing itself, but it's also based on who is interpreting and what methodology or techniques they're using for this. So very dependent on the operator and the disease. So it is essential and important to remember that theory should guide a lot of what we see in the data, that theory guidance can help with generating data, and both of those should drive what we essentially go after. So thinking about then 4 important topics that we carry through some of the examples is who cares? Why do we define the clinical problem we define? And who is this going to impact? Second one is what methods are we going to use? How are we going to think about translating all these fantastic methods? What are the software, hardware requirements? And where in the decision-making process this comes in? And then testing, learning, educating, and going through this cycle. Those of you who know engineering design will know that this mimics the fundamentals of engineering design in empathizing, prototyping, coming up with a solution, and prototyping that solution and testing and verifying and going through this. So in my lab, that is really what we focus on. Innovation within clinical translation driven by clinical problems, testing, verification, and while we are doing this, education and democratization of some of these technologies. I will be focusing in my examples on 2 groups of disease, one cancer and heart disease, which are 2 of the largest causes of death in our century. If you compare this with 1900s, you'll see how different this is. And hopefully, you know, in a century when we look at this again, the recent pandemic and other possible pandemics would not take us back to infectious disease being the largest cause of death as it was 100 years ago. The first project I want to talk about and think about the 4 principles that I demonstrate through this example is prostate cancer. Prostate cancer is a prevalent cancer, the 2nd highest cancer in North American men after skin cancer, and also one of the largest causes of cancer-related deaths. At the moment, the diagnosis of prostate cancer is through some measurements of some blood tests and followed by examination, but the true gold standard is taking biopsies, 12 to 20 samples of the prostate guided by ultrasound. The challenge is ultrasound does not allow you to visualize cancer. So often these biopsies are called blind biopsies. And more recently, magnetic resonance imaging has been used to identify potentially cancerous areas in the prostate prior to biopsy. However, during biopsy, these potentially cancerous areas have to be translated in the coordinate of the patient, and a biopsy has to be taken from there. So the challenges that I had mentioned before apply really very much to prostate cancer. In fact, the picture I showed you before is of prostate cancer histopathology, and the malignancy itself, it's not one type. I have shown you 9 types here according to the division of the histopathology. So my lab and our collaborators have come up with new technology, which is called temporal enhanced ultrasound. The idea is acquisition of ultrasound over time in a very short period without the motion of the patient to the extent possible and transducer. So this time course data, when I say short time, is maybe 3 seconds of data. The idea is that it addresses the major shortcomings of our current technology, which is MRI may be able to identify cancerous locations, but in real time it is not used. Ultrasound is still used for guidance to take biopsies, but ultrasound is not specific. So if using TeUS, you were able to create color maps, cancer probability maps that you overlaid in real time on ultrasound, you would be able to guide the clinician to the location that they should biopsy. This would increase the accuracy of diagnosis and unnecessary biopsies. So the data we collected, as I mentioned, is data in time series. You see videos playing here. So on the left-hand side, you have 2 videos of 2 patients playing. This is TeUS data, 100 frames. What we are looking at is if you can imagine this red point and run that red point in time. So the yellow line is showing the one ultrasound RF line, we call it. So the red point is the point that we are tracking in time, which is the red graph here and the blue graph. Over the past decade, we have been looking at various machine learning algorithms to try and model signatures that are different between cancer and benign tissue using this. We started with the traditional machine learning models and we moved to modeling of time series through hidden Markov models. And the past 5 years, the focus has been on deep learning models mainly. So the first question we asked was, where is prostate cancer? These are 4 color maps from real patients. The project at the moment is in feasibility trials at the NIH Clinical Center in Bethesda, Maryland, with Philips, who's one of the biggest players in the ultrasound space for prostate cancer diagnosis. And the data was collected within that clinical trial. The color maps we created from our deep models were not used to guide the biopsy. So this is all retrospective analysis, meaning the data was collected, we built our models, and we looked at these. So you can see a target that is highlighted on these maps that we have created. A target is where the clinician was aiming to go and take the biopsy, and the target was highlighted because MRI preoperatively highlighted that as a possible cancer area. So with ultrasound, the clinician is aiming to go there. You see that in cancerous cases here, we have red indicating more cancer. So this was all very fantastic. But question is, when you come to the clinical problem, who cares where prostate cancer is? Or if there is prostate cancer? The answer to that from the clinicians is that indolent cancer is really not important. It is not what they are interested in finding. In fact, 90% of men at age 90 have prostate cancer. What is more important to find is aggressive cancer that you need to take a stand and make a clinical decision and do something about it. So we went back to the board, came up with new deep models that would, instead of telling us where the prostate cancer is, or if there is prostate cancer, whether it's clinically significant or not. The clinical significance, or indolence versus aggressiveness, is defined by a metric called the Gleason score. So a Gleason score of 4 or higher is often deemed clinically significant. So our models now predict, in addition to cancer being there or not, the grade of cancer. So now you have more colors in the color map, and there's a yellow and red. I want to take your attention and focus it on this graph here. I don't know if my mouse you can see, but this particular figure here. You see that there's a mix of yellow, red, and blue there, and yellow and red are referring to different grades of cancer. So it turns out, in this case, the clinicians actually in this trial take 2 samples of the same target because they are aware of the errors that are associated in data collection and targeting. Turned out that the first sample from pathology came up as 3, Gleason score 3, that means indolent cancer. If that was the only biopsy taken, that patient would have been put on watchful waiting and nothing would have happened. The second sample from the same location indicated that it was an aggressive cancer and the patient very likely had to have something done in terms of treatment. So the fact that you are capable of having this real-time probability cancer likelihood map overlaid on the ultrasound is extremely important, in particular in this case, as you see it. What I didn't tell you so far, that's the data that we used was data that came from a special machine that Philips had made available in that center that took raw information-rich ultrasound data, RF data. And because it's a time course data, one of the first things you do is you look at the frequency content. So far we had used RF data with frequency content and variety of deep models. Then as GPU essentially power became available to us and we thought about the problem, we thought, why not model in time? And then, the time dependent models were also available. So we went through, instead of looking at the frequency content of our TeUS signals, we looked at modeling the TeUS signals as they were without transformation in the time domain. So we used a variety of recurrent networks and architectures and compared them to take advantage of this time course nature of the data. Turned out that the time information is quite valuable and improves our predictions. Another thing that I mentioned to you is that we were using information-rich RF data. In many, 99% of ultrasound devices, in 99% of clinical centers, RF data is not accessible to a clinician. So the solution that we had built so far was only accessible to very small number of people. So the question was, can we get similar results from B-mode data? B-mode data is the data that you see on your ultrasound image if you have had a scan yourself or scanned somebody or been in the room. What you're looking at is B-mode data, which is post-processed and filtered. So the question was, let's go back to the drawing board and see if you were to use post-processed data, can you still get similar results? So what we did was we used the joint information in RF, so the raw data versus post-processed B-mode data, and we learned from that. And for future just B-mode data, essentially through transfer learning, we were able to classify cancer versus non-cancerous tissue and create our cancer probability map. So on the left-hand side here and right-hand side, I'm comparing our results from the models that were built on the raw information-rich data versus the right-hand side, which was the post-processed data time series. So all of that is fantastic, but real-time implementation is a challenge in itself and has to be thought about. And how are you going to take these images, process them, deploy your deep model, and still be able, in a semi-real-time nature, feed the information back to the clinician? If you have thought about the problem a little bit while I have been speaking here, what you have noticed is that I have been essentially putting pointers for you on targets. That means we have been so far focused on small targets, which is biopsy cores taken from prostates. Biopsy cores are around 2 millimeters wide, 18 millimeters long. Prostate size is between 2 to 3 centimeters in every cubic direction. So what you're building your models from is that you're building your models from that very limited information that you have labels for, because that's what pathology has seen. But the image is being taken of entire planes and you're discarding all of that information. In addition to that, what we have assumed so far is that one label is assigned to these cores. All of the samples taken from that 2 by 18 spatial space. And that the entire tissue in that area is homogeneous and the label applies to all of it, which is not true. So a certain part of this tissue is going to be cancerous, and there will be a variety, heterogeneity of labels within this. So we are taking, right now our solutions have been based on noisy and limited labels, And we are ignoring all the information that we have from our images, but we don't have labels for. So then we thought about going back again to the drawing board and thinking about some unsupervised solutions to come up with better technology and better methodology for this. So what we did was that think about learning from a small number of samples that we have reliable labels for, and then mapping that representation of those samples onto a grid space where the similarity of the samples is captured. For future samples or future parts of the tissue that we don't have labels, all we needed to do was to see how similar these were with the samples that we had labels for. So use a small part that we might have reliable labels and do the rest semi-supervised or unsupervised. So if you look at the projections of the label data, what I described shows itself in practice like this, that a benign sample is mapped more to this corner, a Gleason grade highly aggressive cancer to this corner, and indolent cancer to another corner. So if you create this time similarity maps, in the top left, you're showing how the prostate tissue is similar to Gleason grade 4. So, and you're saying that here, around here, it's in the red area, it's very similar. If you compare its similarity to benign tissue, you see that it's very dissimilar to benign tissue. One of the important facts that we took into consideration was going back and thinking, where is our deep model or our deep models? What are they learning from? And through essentially back engineering of the models, something very interesting came up. When we were thinking about TeUS, although the solution was driven by some theory as well as observations and experience and clinical question, the theory was mostly hypotheses. So when we looked back in our deep models, and that's how they helped us with theory further, was that the low frequency components of the information in TeUS was very important. Thinking about low frequency components, what are the low frequency components in the body? One is your breathing, the second one is pulsation, so your heartbeat. Breathing was not an issue for us because breathing is very slow, and our data acquisition was much faster than the frequency of breathing, but heart rate is around 60 to 80 hertz is what our heart rate is. So what we essentially thought about is a tissue response is a mix of acoustic signal, so the acoustic signal being your ultrasound, essentially the intensity of your ultrasound, the power of your ultrasound signal, and the tissue microstructure, which is your scatterer. So cancer and benign tissue, the scatterers, the cells of cancer are distributed very differently. And if you essentially take how an ultrasound image is created, which is through this one equation I have in my presentation, which is through a convolution of a point spread function, which is your ultrasound signal, with the scattering function, which is your medium, your tissue that you're looking at. In traditional conventional tissue characterization, this is the only term that is taken into account. If your scatterer is moving, has micromotion, at the frequencies that we observed that were important for our deep models, what you essentially can do is you can expand this formulation, first Taylor series expansion of it, and now you have this other term there, which is your ultrasound signal, and its effect on the tiny motions of your scatterers, your cells. And for us, this is the term that adds the tissue typing information and makes TeUS accurate. So we don't have enough patients, of course, to take a lot of data. What we have a lot of is stored pathology slides. So we went back to this pathology slides. We took digital pathology images and we overlaid grids on these. And what you come up with is detected cell nuclei as well as cytoplasm from here. So in a sense, you have been able to simulate a medium, a prostate cancer scatterer, so the tissue itself, just from the pathology. What we did was we put these in finite element models and we simulated ultrasound signals from this and TeUS. What we are doing is we are creating simulated ultrasound from simulated patients, but this is all driven by the theory of it. So using theory, we have access to real patient data. We are taking that information, we are simulating more data through this. In fact, we can create cancer probability maps from this. So through this experiment, we went from a variety of essentially mediums, from agar phantoms that you build that are not live to live phantoms that you embed live cells and medium that you scan, to animal models, to in vivo models, and going around and revisiting all of this. The idea is that you would be able, when deployed, to enhance biopsy and essentially have a cloud ecosystem, which we are deploying right now, where essentially you're able to take the data, learn from the data, do active learning as time goes, and be able to come back with that information to the clinician. Who does it matter for, and what does it impact? In addition to impact on disease, this has huge economical benefits. The prostate cancer biopsy is a $4 billion essentially market for biopsies themselves. 70% of patients go back home with negative biopsies, and ultrasound itself alone is not very sensitive and specific. Therefore, if we were able to reduce this using TeUS by just 30%, that is huge cost savings. Even if you take MRI of these patients, still some patients are sent home and they shouldn't have been sent home. And if you make any improvement, they're small improvements, conservative ones, the savings are huge. The second project I want to briefly talk about is a project actually from a collaborating group. So I want to bring this forward because it is a very important project, and where it went from inception to clinical translation and potential impact. So it's from UBC, from their cardiology group and electrical and computer engineering, Dr. Abel Masumi and Rollings groups. Heart disease was one of the diseases I highlighted there for you on the pie chart as the second or the first, depending on where you look, cause of death in the world at the moment. There are a number of modalities imaging available. Echocardiography, which is ultrasound based, is one of the more prevalent imaging modalities. It's harmless, accessible, cost effective, real time, standard of care, but also it's noisy. And it is extremely, that the quality depends on the machine and the operator to a very large extent. So the purpose of here was, as the area moves from cart-based to mobile devices, is it possible to essentially take advantage of theory and what you know and high quality data and deploy that through deep models to point of care and low quality images, or for technicians or technologists or clinicians that don't have as much experience? So what that meant was that you have a less complex hardware, but for your AI solutions, you have low quality images and low temporal resolution. If you have less experienced operators, that means there's higher variability in your models and the data that your models have to learn from. And then because you're going to handheld devices, you're removing the theory altogether. So what they did was they took a decade of echo data from multiple hospitals within Vancouver. They had experts annotate those for their quality frame by frame, and they learned through deep models for this. And what they deployed was two things: the ability to take low quality data and come up with metrics for how quality could be improved, and then to assist the physician in some of the measurements in this data. So to have an assistant for the physician. I want to run this app that has been deployed, and you see that there is a bar there. So this is a handheld device that is scanning the heart, and a bar is coming up based on the deep models as to what the quality is, and it's in real time giving feedback to the clinician onto how to improve. So behind all of this is, how do you deploy this? Behind the user interface, there's a deep learning core and a variety of methodology that they have published, and more recently, adversarial model. What was interesting in that study, and I wanted to bring here, is also something that we are seeing in more recent studies and some of the recent COVID papers with imaging and so forth, is who is the AI helping? They did a study, this is a couple of years old, I think, by now, and they compared the performance of a small number of clinicians, but did they use this information and did they benefit? And in their study, what is very interesting is that the people that benefited very much, so between the left-hand group of bars here and the right-hand, there's a true missing here, is that people that were kind of mid-career were the ones that benefited more. The final project that I want to briefly touch upon is a very recent project that is happening in our lab, and again is a collaborative project between multiple groups, not just at Queen's, but across the globe. And it is with another aspect of cancer, but very important aspect, which is resection and margin assessment. So for many solid tumors, still surgical resection is the gold standard for treatment and possible cure. A negative margin and positive margin are terminology that are important not just for understanding, but they affect the clinical outcome and the patient outcome. Hugely negative margin, which is what everyone strives for in surgery, is to be able to resect all the cancer cells as well as some normal margin around it. Positive margins is when this is compromised and essentially either cancer is left or behind in the body, or cancer is on the edge. If you look at a study that was published a couple of years ago in Scientific Reports from Orozco et al. It shows that positive margins, it shows some of the positive margins in 10 most common solid cancers. For men and women, it's different, the solid cancers. In women, ovarian cancer, bladder cancer are quite high. Breast cancer is high, it's pink somewhere down here. I'm going to talk about breast cancer briefly. In men, prostate cancer in particular has a very high positive margin, and then the oral cavity cancers in both men and women have high incidences of positive margins. If you look at breast cancer in particular, in institutional reviews, anywhere between 11 to 60% positive margins are left behind, meaning out of 2 women that go for breast cancer surgery, 1 is recalled for further surgery, which delays then a lot of very important, depending on what they have, chemotherapy, radiotherapy, and a mix of treatments. There are a variety of methodologies that are being presented in the literature, research literature mostly, for real-time margin detection. So this means in the operating theater, maybe not happening while the patient is on the operating theater, so while the tissue is being cut or burnt, but when the tissue has been resected, it is taken perioperatively in the operating theater and looked at. Through pathology approaches, staining and so forth, variety of new innovations in that. Optical approaches, so Raman spectroscopy, acoustic approaches based on ultrasound, and again, another group which I'm going to focus on, which is on mass spectrometry. So looking at intensities of mass to charge of ions. One of the technologies that is a very recent technology in the world is the intelligent knife, or the eye knife. It is based on real-time, essentially, mass spectrometry. And the idea is that while the surgeon is cutting and burning the tissue using a cautery device that you see in the cartoon here, they're suctioning essentially and ionizing the metabolites that they're cutting through from the tissue they're cutting through, running that through the mass spectrometer. And you're able, based on the signatures of what you're seeing through the mass spectrometer and the variety of metabolites that you're getting there, you might be able to separate the type of tissue that the surgeon is cutting through. So here I'm showing you what the screen of this device looks like, and they have a simple LDA PCA model already built in the device that, you know, tells you based on where you are. So this is on the x-axis of the signal, you have the time, and the y-axis intensity of the spectra you're seeing. And in this case, in this red area, the system is telling you that you're cutting through the tumor. So we wanted to know if we can use the data from Reams and iKnife to not only detect the tissue type in excise model, but can we take that intraoperatively and make it happen while the clinician is cutting and excising the tissue. Similar to this previous two problems that I showed you, the data is very noisy, obviously, and the labels are noisy. This is showing a cautery device and the pathology of what is cut. The cautery device is a large tip device. Therefore, when it burns, depending on the speed of burn, the angle, you can really quickly get through a tissue and destroy. It's destructive. So your burn is not necessarily from a very clearly defined type of tissue. The second issue is that the labels, because this is destructive, a pathologist can only guess what you burnt. So your gold standard is really determined based on the pathology of the surrounding tissue of the burn. And it's only a speculation of what it is that you have burnt. So for our proof of concept, we went with basal cell carcinoma, skin cancer that is prevalent. Large clinics are run at our institution with many patients in the clinic. One of the advantages of working on this particular problem is that positive margins are not necessarily as critical because BCC doesn't metastasize. Therefore, pathology is more comfortable with us burning tissue because this is destructive, as they're not as concerned about margins. So what we did was the tissue was resected, and in the operating theater, we burned the tissue. The pathologist was there. So by visual inspection, they told us, this is BCC, this is cancer, this is not cancer, burn these two areas. So you can see here that we are burning tissue. So through a variety of deep learning models, essentially we were learning from the burns to determine whether we can tell apart BCC from normal tissue. We don't have that many patients. This is still going to the OR, for those of you who are familiar, is a huge overhead. So since our data is noisy, we took advantage of it. We modeled the noise and we came up with augmented data that mimicked the real data. And our results looked very good. This shows some of our samples, close to 40 patients in our test set, and our models were doing well. The variance was relatively small, but for certain samples, we weren't doing all that well. So the question for us was, is it our models, or is it the nature of the data that we have mixed burns and that our pathology is mixed? So then we went back to the drawing board and we said to ourselves, we cannot assume a label for a burn. This is in fact a multi-instance learning problem where we have to assume bags of labels. So as we burn tissue, collectively, sequentially, we take a number of burns and we call them a bag. What is important is that any positive, any cancer burn there is important and should be a red flag. So it lends itself very well to the essentially methodology of multi-instance learning, and we built some models. A lot of what I'm showing you is very, very recent and is under review. It hasn't been published yet. So our results using a cautery tip that is a regular cautery tip, depending on the involvement of cancer and the length of the bag, can be as high as 92 or 3%. We went back and we said, what if we make a fine cautery tip? So be very precise in our burns. So we used our old data as training. We extended it to a new cautery tip, so a new device. We still are doing relatively well here. And then the next step was, how about we deploy it to real cutting. So clinician took their cautery and they were taking the samples, and what we were doing was we were sequentially bagging the intraoperative data. And in the 3 samples that we have so far been able to collect, our accuracies look good. So for BCC, the impact isn't as large, but for breast cancer, it is large. I showed to you that the positive margin rate can be as high as 60% in some institutions. So we tried this on a small collection of breast cancer patients, so around 20 patients. This is still in review. And our results were our accuracies and predictions of this is perioperative data are as high as 96%. We have just deployed this intraoperatively, and I want to show you 3 cases. These are intraoperative cases. A mastectomy case, a positive margin, and negative margin as determined by pathology. These are the predictions of our deep models. And you see that our deep model in time is telling us that this mastectomy had some positive. It's showing us for the positive margin some positive, and also for negative margin. So we wanted to go back and see what is happening here. As you might have thought and thought to yourself, if a surgeon is using the device and cutting through tissue, you would not know where you are in the physical space. So if they cut through cancer, and if you screamed cancer or the device screamed cancer, there's no way for the surgeon to know where they were 2 or 3 seconds ago. They have already cut and moved on. So for them to be able to go back and find that exact location, we had to have other technology to track the cautery device. We do that using ultrasound and electromagnetic tracking. So we are able to scan the patient preoperatively, have the tumor, breast cancer identified, and then we put a boundary around it. And in real time, we can track as the clinician is cutting. We not only know the metabolites they're cutting through, but we know the position of where they are. So I want to take your attention to the 3 samples there. One was the mastectomy. So mastectomy was a large resection, the entire breast went. And right at the beginning of this, we noticed that when the surgeon, the method of communication right now is a scream and click or shout and click, which is they said, I'm cutting through skin. We noticed that there's red by the device, and our models are also saying that I'm detecting red. Turns out that the cancer was very superficial and large. So when the clinician thought that they were still in the skin, they might have been just past the skin. And because the tumor was superficial, they might have actually looked at the tumor. Here you can see at that exact time, this is where we were using our tracking. And this is our tumor margins. And you see that it has turned red. It's normally green, means that the tumor margin has been essentially, you have crossed the tumor margin. The second case was the positive, as pathology told us. And then the last case is essentially where pathology thought that we had negative margins, but in fact, our tracking showed us we had positive margins. So I want to end this with essentially coming back to the slide that I had, that the clinical problem, your methods, their translation, and their verification are a loop and very important. We do a variety of projects in the lab, and all the information is here, and I welcome any questions you may have. Thank you.
So much. I'll give some folks time to think about questions. I know I learned a lot in this talk. I like how you mentioned when you're talking about prostate cancer, how even the smallest improvements can lead to huge gains, like, you know, saving money, saving lives. Because usually we think of, oh, you know, if something improves by just 1%, it's not that much. But actually in this field, it can make a huge difference. So that's great. Yeah, if anyone has questions, you can just unmute and ask it directly. It's easier than using the chat. People are always shy on Zoom.
How about I ask a question? Can people raise hands here or no?
Yeah, people can use the reaction buttons.
Reaction buttons. How many people that were on the call work in the medical area? Help me out, Yasmin. What are they supposed to do? Raise their hand or?
Yeah, I see a couple hands. Christopher, Carson, Parsa, Ali Reza. Yeah, Farnak. So yeah, a few people will raise their hand.
Few people. Okay, next question is those who don't work. So a lot of people that were on the call don't work in the health area. Did you find any parallels with the challenges we have and other area challenges? I'm sure we are not unique in these challenges. And are there any solutions that you saw that you already have, but we are struggling with?
Someone, Laura, is that a raised hand? Feel free to just unmute yourself and speak if you need to. Wow, tough crowd. Maybe these questions are too tough. You have to think about it.
They are tough, yes. It's not necessarily straightforward to see all the solutions, but it's just something to think about. Is if you're in finance, if you are in other areas, production, machine vision, all sorts of other areas. What are the parallels that you see? Natural language processing, what are the parallels that you see between our challenges, the variations we see in our data, in our labels, and how that's guiding us, or rather we are struggling through them to come up with answers. The other thing to think about is also, how do you translate your solutions? And is it easy in your field to translate what you develop, to deploy it right away? Or is it that most of your effort, like ours, goes into thinking of the problem and deploying it rather than developing the algorithms?
Parsa, do you want to say something?
Yeah, hi Parvin, thank you so much for your talk. Actually, I'm working on a medical field, and I'm working on EEG time series for detecting people with schizophrenia and people that are healthy. And actually the solution that you mentioned for time series was really, would be useful for my side. And I have a lot of time series, and if there are a lot of features, but a few samples. So somehow I cannot use deep learning algorithms because of the lack of data, and I need to find some solution. For example, one of the solution that I'm using right now is transfer learning and using MAML. So I think that we are people that are working on medical domain always have problem with lack of label data, as you mentioned, and lack of actually gold data that is necessary for providing right diagnostic and identification between healthy people and patient.
Thank you. Thank you. That's thank you very much for sharing that.
At the hour now, so folks might have to jump off. But maybe, I'm not sure if you're available by email or
yes, absolutely. Email, come visit us in person, virtually. We are here. I see many of my students also here. So that's fantastic. Talk to us, talk to them if you prefer to talk to them. They did all the work I just presented. So it's sometimes better to talk to them. Yeah, please come visit us, talk to us, email us, and I look forward to being there in person at some point and connecting faces to all the names I see on Zoom. Thank you very much, Yasmin, for this.
All right, bye everyone.
Okay, bye-bye.